Hi, good morning. We're going to go ahead and get started. This is Beth Lucas, and this is our fourth of 4 webinars that we are conducting on the new clinical requirements in ACCS. Today we have the pleasure of being joined with someone from outside of the agency. We have Lee Ellenberg with us today, and he will be discussing SBIRT with us. So as I typically do, I do start each of these with just a really broad overview of why we are talking about screening, assessment, treatment planning, and service delivery in each of these webinars. So I'm just going to spend a couple of minutes doing that, and then we're going to, Lee is going to walk us through an overview of SBIRT, provide some examples, and really show how screening and the SBIRT model really informs the care being delivered. Okay, next slide. Okay, so as we've discussed in each of them, the kind of core of ACCS is ensuring that licensed clinicians are accountable for the full array of services that are being delivered to clients in ACCS, including how they're being engaged, involved in assessment and treatment planning, that clinicians are directly delivering services and supervising through teaching and modeling clinical interventions. I'm not going to go as in depth as we have in some of the previous. What I really wanted to emphasize for this session is that we wanted to make sure in ACCS we were building in the capacity to provide treatment to individuals that had needs related to their substance use. And we wanted to make sure that the licensed clinicians are competent in screening and assessing, that the licensed substance abuse counselors and the recovery coaches are really supporting that work and providing direct interventions to individuals, and that there is a growing comfort and competency within the ACCS service model to be able to provide a full array of treatment that is supportive of their needs related to substance use and mental health, and that they're able to interface with other addiction services as well. So with that, I'm going to kind of skip over the rest of the slides related to the clinical requirements and turn over to Lee Ellenberg.
Right. Okay, thank you, Beth. And thank you all for having me here. So let me introduce myself a little bit. If we could go to the next couple slides. I think it's the next, keep going. That's one more, and then we're going to go back. So I just wanted to talk a little bit about kind of who I am and the organization, the program that I work with. So I'm the training manager of a program called SBIRT Training and Technical Assistance Program. And we're based at Boston Medical Center. Our funding comes from the Bureau of Substance Addiction Services. That's the Bureau of Substance Abuse Services is an old name. It's been changed to Addiction Services, but it's still BSAS. And our funding comes from BSAS. And what we do is provide training and technical assistance to any healthcare human service organization throughout the state that's interested in learning about SBIRT and implementing SBIRT. And because motivational interviewing is so woven into the SBIRT process, that we're also provide MI training to any organization that's interested in that. So we do both SBIRT and MI training. If we can go back a slide. One more, back one more. Okay, so when we're talking about SBIRT, just so that make sure we're all on the same page, SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And when we talk about screening, it's using a validated screening tool that's has some research behind it to identify people with what we call unhealthy substance use, and I'll be defining that shortly. So it's a universal validated screening tool followed right afterwards by a brief intervention for people who are positive, meaning they indicate some unhealthy use of alcohol or other drugs. A brief intervention is a conversation about the screening results. I'll talk a little bit more about that later. And for people who are negative, meaning they don't have any unhealthy use or don't disclose any unhealthy use, that we recommend a conversation to support and reinforce those behaviors, those healthy behaviors. And there's a format called REACT that I'll talk about that might be helpful in kind of having that conversation for people who are not using. And then lastly, for consumers who indicate more potential substance abuse diagnosis or substance disorder diagnosis, that a referral to specialized substance use services is recommended. So that's what we're talking about when we talk about SBIRT. So let's go to the next slide. One more. Okay, so just a little background of where SBIRT comes from. SBIRT was originally developed basically for primary care healthcare settings because we know that 1 in 6 patients, or about 86% of the population, had never had a conversation with their healthcare provider about their use of alcohol or other drugs. And you can see in this cartoon the elephant's visiting his analyst and is saying, "I'm right there in the room and no one's even talking, no one even acknowledges me." And that, I think, is very true around substance use in healthcare settings, including behavioral health settings that I know as a social worker myself, that addressing substance use and mental health issues were seen very separately and seen as almost discrete professions or processes. So we're in the era of integrating behavioral health. We want to integrate substance use as part of behavioral health. So that's why SBIRT was developed. And that we know that substance use has a tremendous impact on people's health, including their mental health. And even in what we call risky use, not just people with a substance use disorder, that we know it certainly can impact common medical conditions like hypertension, diabetes, and certainly depression and anxiety, which is, part of why I'm here today to talk about how substances impacts depression and anxiety and other mental health issues. Certainly that there's good research to show that unhealthy use of substances can impact people's adherence to medication and other medical regimens, certainly increases accidents, injuries, lots of impact on behavioral influences. And that in youth, we know that substances can affect brain development, given that the brain continues to develop till age 25, and that marijuana has been associated with psychosis, and it may impact that. Impacting the brain could impact learning and memory for people under the age of 25. Okay, next slide. So we're talking about unhealthy substance use. So in SBIRT, we're not only identifying people with a substance use disorder, but we want to also identify people with what we call unhealthy substance use or higher risk substance use. So when I talk about unhealthy substance use, I'm talking about both people with a substance use disorder, people who kind of use substances compulsively and uncontrolled despite negative consequences, but also people who are drinking. Most of the studies around substances is around alcohol. There's less good research around other drugs because it's very difficult to do research on illegal drugs. But for alcohol, at least, we know that there are guidelines in terms of what's considered higher risk substance use. So we're going to talk about that. By substances, we mean alcohol and other drugs. And then the question there, is there healthy substance use? And often I get asked, well, what about drinking a glass of wine, each night? Isn't that supposed to be good for your heart? Fortunately for some of us, that research is really being refuted pretty significantly, and that it's not considered good research at all, and that we know that some of the research around healthy alcohol use has been funded by the alcohol industry, so it's very questionable. In fact, more guidelines have come out recently that look at alcohol and its negative impact on health, and we know that even risky use of alcohol has been associated with certain cancers, breast cancer, throat cancers, esophageal cancer. So there is, so whether there's healthy substance use is questionable. And then lastly, any kind of use, substance use by adolescents is considered risky, again, because of their brain development. So let's go to the next slide. Okay, so historical perspective that initially in the fields, behavioral health, medical health, that we would think about substance use, either people had a problem, a significant problem, or we can go back a little, just one click. So it's kind of people had a problem, and anything short of their life really unraveling and creating major significant upheaval, then it was considered it's not a problem and wasn't really addressed. But now we can go forward. But now that we know, another click forward, let's go forward. Now we know that we can think about substance use similar to other healthcare problems, and that there's a risky period. This is, again, particularly for alcohol use, again, because that's where the research is. And that's similar to other illnesses such as diabetes or hypertension. There's a period of risky use. So for diabetes, someone might have high blood sugar, and so they would not necessarily have full-blown diabetes, but we know that they are at a higher risk for developing diabetes. Or similar, if you have high blood pressure, you may not have cardiovascular disease, but certainly are at risk for developing that. And similar with alcohol use, that we know that in that risky period, people may be at higher risk for developing a substance use disorder, but even if not, that we know there are medical implications of having higher risk use. So then the question, of course, is what do we consider higher risk? And that there's been some good studies to look at populations, and that the National Institute of Alcohol Abuse and Alcoholism, NIAAA, put together these guidelines for what's considered higher risk drinking. So for men under 65, having 4 or more drinks in one occasion or one day, sometimes it's written as 5 or more drinks a day versus more than 4, so 5 or more drinks a day, or more than 14 drinks in a week, would put them at higher risk for health problems and safety problems related to their drinking. For women and men over 65, the guideline is having more than 3 drinks, sometimes written as 4 or more drinks on one occasion or one day, or more than 7 drinks in a week, would again put themselves at higher risk for developing health problems or safety problems because of their drinking. So just to be clear that we're not saying that if someone drinks above those amounts, they have a substance use disorder. They may not, actually, but they are at kind of higher risk, again, for health problems and safety problems. And for drugs, we consider any kind of illegal drug use to be considered higher risk. And that kind of brings up the question about marijuana, and that that's another discussion that we can have maybe towards the end, where marijuana fits into now that it's legal, even though there aren't great studies about what's a less risky use of marijuana. We actually don't know that. So those are the guidelines. There's 2 or 3 caveats that I need to add to that slide, actually. So those are for women, women who are pregnant or women who are considering becoming pregnant are advised not to drink at all. That's kind of risky for the development of the fetus. So that no alcohol is recommended. And for people with on other medications or people with other medical conditions are advised to talk to their healthcare providers about their use of alcohol and how it relates to the medication or particular condition, which I would think would apply to most of the patients in DMH. So that's worth considering and are talking about. Okay. So the other question is then, we're talking about drinks, what's considered a standard drink. And by a standard drink, we mean 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of hard liquor. So just to give you a little context for that, in that red Solo cup, the top left, the second line from the bottom, the first line is 1.5 ounces. So if you're having I don't know, some vodka straight up, it would just be that much of vodka. The line above that is for wine. So a glass of what's considered a standard drink, a glass of wine would be up to that second line on the bottom. I think the whole Solo cup is 12 ounces actually. So it's particularly, useful to think about when you're talking with adolescents too, because when they drink, they often might take a Solo cup and just pour in a bunch of vodka or something into that cup, and so that's often way more than what's considered a standard drink. So let's go to the next slide. We can go through that. So what we're seeing now, you can click 2 more clicks, that we want to think about substance use as a continuum now, a spectrum disorder, certainly from people who are kind of abstinent to people with a full-blown or diagnosed substance use disorder. And SBIRT in particular, I think this is important, really focuses on identifying people in that higher risk category. That they're people who are not necessarily on your radar. So that's really where we want to, why I think SBIRT was developed. People are pretty good. We know in terms of, I can talk about physicians are pretty good at identifying people with a substance use disorder, but what they're not good at, but they kind of miss a lot of people. When they kind of figure out if someone has a substance use disorder, we know that's fairly accurate, but a lot of people get missed. And so around this unhealthy substance use, there is a lot of people getting mixed. That's why, here, the next slide, that's why we recommend that when you do screening, do one more, that it's universal, meaning everyone gets screened, asking, so the question is, who in these pictures has the substance use disorder or has unhealthy substance use? And the answer is, we don't know. That's why we need to ask, and we need to ask in ways that people are more likely to be forthcoming and open. So let me just digress for a little bit, because often the question comes up about whether people are going to be open or honest about their use of alcohol or drugs, given the stigma that's connected to substance use and the judgment and criticism that people often expect, particularly from healthcare providers. I'm sure it's similar with behavioral health providers. So, before we're asking the questions, we want to kind of assure people why we're asking the questions, and we're asking the questions because it's about wanting to provide good health care, good behavioral health care. We're asking the questions of everybody, not just anyone who's being singled out. We're not asking you these questions because of the way that you look or kind of you've been acting funny, and that the answer to these questions are confidential, like other healthcare information that you provide. So it's often helpful to let people know that information, because we really want to encourage people to be forthcoming and open. Otherwise, it doesn't make sense to ask the questions. We want to get accurate results. So the questions that we look at are validated questions. This is what's called the single item alcohol question, even though it's really 2 questions. But the first question is, do you sometimes drink beer, wine, or other alcoholic beverages? If the answer is yes, then the question that you want to ask is, how many times in the past year have you had 5, this is for men under 65, 5 or more drinks in a day? For women, it's 4, and men over 65, 4 or more drinks in a day. So that's the validated question. That's that kind of number for the drinking guidelines, higher risk drinking guidelines, and that's going to identify people who are drinking over that guideline. All right. If the answer is anything other than 0, that means at least once in the past year the person drank over the guideline. So there's some risk involved. There might be a small risk, but there's some risk nevertheless, so that we want to do more assessment and have more conversation about it. If people are positive, meaning they have drank over those guidelines, we can do an assessment to find out the severity, the extent of the drinking using other validated tools. It could be the CAGE aid, which is just 4 questions, or the audit, which is 10 questions. The assist is a little more extensive, or TAPS is a brand new screening tool that's also been has some good validation in its studies. So that's the validated single item question. Let's go to the next slide. This is the single item validated question around drug use. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Again, if the answer is anything other than 0, then you want to do a further assessment using, again, a validated tool. And one more slide. And for the CRAFT, we recommend, for adolescents, we recommend the CRAFT, which is validated for people between the ages of 12 and 18. And that starts off with 5 questions, and then there's 5 more follow-up questions, or actually 6 more follow-up questions. Okay, so let's go forward. Let me just say briefly about the brief intervention that for people who are negative, meaning there's no kind of unhealthy use, that this is an opportunity to have some good conversation, discussion with people about alcohol and other drug use. So if people are not using in higher risk levels, it's good to have a conversation to kind of support that and reinforce that behavior. If people are using in risky amounts or potentially have a substance use disorder, then you want to have a brief intervention. So this is where, again, since SBIRT was developed in a medical setting, where we might think together how it might be modified or shift a little bit in a behavioral health setting, because the brief intervention by definition is brief, it's non-confrontational, directive conversation, and really relies on MI principles and strategies. It's brief because this was developed, again, in a medical setting where providers don't have more than 5 or 10 minutes. It's different in behavioral health where you do have more time so that it can be extended. But the point of it is really to have a conversation that's kind of addresses the results of the screening in a way that can be collaborative and non-confrontational, and again uses motivational interviewing. For the next slide, for people who are negative, meaning people who have no use, the REACT model is a good model to kind of reinforce that behavior. It stands for reinforce, educate, anticipate challenges of tomorrow. Some examples of what you could say: your decision to avoid alcohol or drugs will protect your health and safety. Tell me how you made that decision, so that you have some conversation so that it feels like a conscious decision to not use. If you're providing some education or information, whether people are positive or negative, we recommend the provide illicit formats. Comes from motivational interviewing, sometimes called the MI sandwich, where you certainly ask permission first before talking about alcohol. So here in this example, the provider asks, is it okay if we discuss alcohol and depression? Find out what the patient, consumer already knows about that. What do you know about how alcohol affects depression? And provide the information, and then always following it up with the patient's response. What do you think about that? How's that fit for you? And that's a really good way to provide information so that people are more likely and able to take in what you have to say. Let's go to the next slide. And then it's always good to find out if people perceive or kind of think there might be challenges to maintaining those healthy decisions, and kind of certainly ask about that. What do you kind of anticipate having that decision being challenging at any point, and do some brainstorming about how to address that and help the consumer figure out ways to manage more challenging situations. Next slide. So the brief intervention for people who are positive that follows the screening can take lots of different forms. Again, it was developed, the notion comes from healthcare, physical healthcare, where time is very, very limited. But the essential pieces of a brief intervention is a pretty broad term, and there are lots of different types of brief intervention. Essentially, it should include feedback about the screening results, some advice if you want to make recommendations for a change in behavior, but doing it in a way that's MI adherent and MI consistent, and then negotiating a goal for change, again, using MI strategies. So we really want the patient to come up with their reasons for change as well as their way, how they might change. Again, you can use readiness and assess their readiness and confidence to make the change using MI strategies once again. So there's another format that's not on the slide called the brief negotiated interview, which is a very almost scripted format to have a brief conversation with someone. Again, using its MI techniques, but it's a pretty quick 10-minute conversation that can really move people towards identifying their reasons for change and how they might change. And that we recommend that certainly for healthcare providers where time is really limited. But, so in summary, that SBIRT is an evidence-based model that ensures unhealthy substance use is identified and addressed using validated screening tools so that we're not just asking, you don't drink, do you, or are you just a healthy drinker? And then immediately follow the screening, a brief intervention, a conversation occurs around the results of the screening and kind of reinforcing positive, healthy decisions and helping people make changes around less healthy decisions. And then certainly people needing further services could be referred for substance use specialty services. So that's SBIRT in a nutshell. Okay.
So
Okay.
Oh. Will the questions be adjusted with the legalization of marijuana?
So the alcohol question obviously will stay the same, and yeah, the drug question is illegal drugs, use of illegal drugs, so that as marijuana is legal now, so that marijuana would not necessarily fit into that. You could ask if people are using, if the people are using other substances, you could add a screening tool called the CUDIT, which I'm only a little bit familiar with, which is particular to cannabis use. It's the Cannabis Use Disorders Identification Test. It's like 10 questions though. Mm-hmm. So we're not sure. We're kind of really trying to figure this out. This is really in the beginning stages of figuring out how marijuana is used.
I think what we'll do now is we'll open up the lines to see if anybody wants to ask a question. Please feel free to type in the chat, or we have now unmuted all the lines. Are there any questions that folks want to ask? I have a question. Mm-hmm. So in a setting such as ours, where we're providing services to a person over an extended period of time.
Thank you.
We're going to just put back on mute, but please feel free to type questions if you providing treatment over an extended period of time. We've certainly done an initial screening assessment, comprehensive assessment when they come in. Many of the individuals we're working with have known substance use that may vary over times, including times where they're not using at all, using in a more risky way, or using in a way that's, achieves the clinical diagnosis. Mm-hmm. So my question is, we have been talking within the model that we're using SBIRT, we're using motivational interviewing kind of throughout, we're using harm reduction techniques and so forth. But how the SBIRT model, how to think about the SBIRT in our setting, and particularly where a person's use may change over time, and a person, may have periods where they're not using. How to think about SBIRT in approaching an individual, to kind of think about, are we asking the questions at times where we may think there might be a change in their pattern of use or in their use at all.
Right. So in certain ways it's new territory, but I think, some of the kind of components that are the kind of essence of SBIRT is really useful in terms of asking, thinking about how you ask, what questions you ask. To ask questions that are validated, that we know there's some research behind. And really, SBIRT was developed because people were being asked, again, you don't use substances, do you? You don't drink, or you're just a healthy drinker, or, I recently was seeing my physician, and the medical assistant, she said something like, no, don't smoke, no, right? And, she was trying, I think she was asking about my smoking, but I had no idea what she was asking. And, clearly she didn't want to know the response. So, and that we know that happens with alcohol and drug use, so we want to really avoid that. So we want to have some clear, very good questions that are validated, that we know there's research behind it. So that I think periodically asking some of the single item questions is really good. If people are well versed in motivational interviewing, then they can continue to have those conversations periodically with people. And that the other issue is around stigma, that, when the topic of substance use comes up, that people, immediately feel like they're going to get lectured or judged or criticized, for drinking at all or for using drugs. And we really want to move away from that, so people feel open to kind of talking about it, so that you can have effective, useful conversations. So I think if you can establish that rapport with a patient, and establish the notion that, we can talk about this without you feeling worse at the end of the conversation, I think that really will capture the essence of SBIRT.
Thank you.
Okay.
Are there other questions? We've unmuted all lines again. So if you have any questions, feel free to speak up.
Hi, I have a question.
Sure.
So what screen tool are you using? Is there one particular screen tool you're using in conjunction with the SBIRT?
So SBIRT doesn't specify a specific tool. It just specifies using validated tools that are kind of have some good research behind them. The single item questions that I mentioned are really good because they identify people with risky use versus people with a substance use disorder. So, like, for example, I would not recommend using just the CAGE or the CAGE AIDS for questions, but that tool was developed specifically to identify people with a substance use disorder. And we're really looking for people with substance use disorders, but also with unhealthy use too. So the CAGE would not, in and of itself, would not be an appropriate tool, but you could use the CAGE and the single item questions. So it's, you want to, the audit is a good tool. The DAS is okay, it's not great, but for drug use. So as long as, any tool that has been validated is the right tool.
And I also just want to clarify as far as the requirements of ACCS providers, so that we do require that their screening and assessment process include a validated instrument. We did not determine what that tool or tools would be. Providers have implemented and are using a variety of tools, and so we wanted to give providers the flexibility to either continue to use a tool that they have implemented within their settings, or to choose tools and provide the training specific to those tools. So we don't require any specific tool, but we do want to see that they are using a validated instrument. We can also send out after this call the link to the MA SBIRT website.
Yeah, yeah.
I've actually, as we've been working on ACCS, I've used that a number of times. And it's a good resource, and there are links, that you can follow from there. So I think it would be good if, we can just send that out to everyone, because it's a good place to kind of follow up with additional questions. So.
Great, thanks.
We'll unmute again. If there are any other questions.
So my follow-up question is this, then. That'd be good then for whoever is we're working with, to share what assessment tool they're using, so we'll be knowledgeable about that then, right?
Yes, I think that would be a good part of the contract monitoring meetings to review what they're using and to talk about how they're using it. Because I think, one of the themes that we've talked about throughout these is that the result of a good screening and assessment and clinical process results in good clinical documentation, but the documentation is a product of really good work happening in the human space. And so, we want to know what they're doing, what they're using as tools, but even more importantly, we want to understand how they're using it and what they're learning from the people that they're serving and how they're incorporating that new information into the treatment that's being delivered. But I agree that's important information to know in contract monitoring is what tool they've selected, why they've selected it, how they're training their staff, how they're reinforcing that training to ensure that it's being used in a consistent way. Because I think as Lee was talking, it's really easy to convert, if we're at all uncomfortable, to convert those validated questions to, you're not using illegal drugs, are you? And, those types of things as we've been talking about.
Right. Just to add to that, so, if people are using when they are using the single item questions, just to pay attention to the way it's written, that it should be asked exactly as it's written, because that's how it was validated. So it's how many times in the past year, not have you in the past year used an illegal drug or drank more than da-da-da-da-da. So it's a have you, how many times versus have you. So it's not a yes or no question. So that's important, actually.
Did that answer the question or
Yeah, and I would assume that they would share the results with us, and as case manager, other DMH personnel, and we'd also be, whatever tool they use, the written material as well as the all reports they make, will be shared with the case manager, other DMH personnel that are working for particular clients. I would be correct to assume that, right?
Yes. I would agree with that. Any other questions? Well, I want to thank everyone for joining these. This is our last session. We will be checking back in to identify if there are other needs or to kind of reinforce or the information that we've been providing in these. But thank you for joining us over the course of this month.